Hey everyone, and welcome. I'm Jeff Rubinoff with DEXA Plus, and I want to thank you for taking the time to join us today. Now, whether you're a physician, practice owner, clinician, health optimization provider, or someone interested in delivering better outcomes, we're excited to have you here. Today, we're going to discuss one of the biggest shifts happening in healthcare, performance medicine, and longevity, the move from guesswork to clear, measurable, data-driven decision making. We're going to explore how DEXA for body composition, resting metabolic rate, RMR, and VO2 max testing work together to create a powerful metabolic intelligence system that helps providers deliver more personalized care while improving patient engagement, patient retention, and also your patient outcomes. And to help us break all of this down, I'm joined by someone who has spent years helping practices implement these concepts. That's right, in the real world. Eric Martinez is widely recognized for his work in health optimization, body composition, metabolic testing, performance programming, and helping providers build systems that create meaningful results for their patients. Eric, thanks for joining us today. For those who may not know you, tell us a little bit about your background and how you became so passionate about metabolic health and optimization.
Thanks, Jeff. Thanks for the highlight, basically, of my introduction. So it actually started with my own personal journey. I used to be a really chunky kid with asthma, kind of like pre-diabetes, and I wanted to get into baseball when I was younger. And the very first day I went out for practice, I got hit by a fly ball, and all the kids made fun of me. So instead of like losing my mind, I decided to say, hey, it's time for me to lose weight, get better, train. And that kind of started a cascade. I started exercising, eating better. I came across a bunch of books to learn about physiology and anatomy as a kid. And eventually I came up, and a book that came out was ACSM, American College of Sports Medicine. And in there, something called the Registered Clinical Exercise Physiology is what kind of stood out to become one. I said, I'm going to do that. And ever since then, I started my journey. I got to the point where I did my master's degree in exercise physiology. I got my registered clinical exercise physiology licensing and certification that made me one out of 1,000 in the United States to have this title. And then from there, I started working in rehab settings, pulmonary rehab, cardiac rehab, oncology. I started working with more metabolic diseases, and that became my specialty. At some point, I partnered up with a PT clinic, and there was this ongoing issue of people coming back for pain. So then I'm like, okay, we need to now figure out why people come back in pain. And that started the whole rabbit hole. And that's where my business really started taking off, where we needed to look at the person as an integrated whole rather than just looking at one system, looking at one thing. Exercise cannot resolve a nutrition problem. A nutrition problem couldn't resolve a mental state problem. All these things could not resolve what's going on in that person. So that rabbit hole led to me working with professional athletes to optimize their performance, and also working with people with chronic diseases or pain to bring them to higher levels of performance. Now I'm known for working with people who have cardiovascular problems to run marathons. Those are the cases that I like working with now. And with that, I opened up a practice, an integrated facility where we did testing, we did strength conditioning, we had all the recovery services, PEMF, cold plunging, hot tub, sauna, all the biohacking modalities, and we had functional medicine along with chiropractic and PT. Because again, we wanted to look at the whole body. And then shortly after that, I left from the company that I was making $1.2 million a year from. And as the operating officer of that business, I started getting approached by other companies to help them navigate through the headaches of having an integrated space that's either focused on performance or longevity or biohacking, and really guide them into the direction of how can I make that business successful alongside with all these unique devices and all these vendors, and helping the vendors to actually connect with the businesses and make sure that everybody's winning, that everybody's succeeding to do one thing, which is to provide the best care possible for the client, and making sure that they're able to stay in business to provide the best care they can. And that's pretty much my story in a nutshell.
I like it. I like seeing the passion derived from a personal kind of experience. Everyone that I've met within the health optimization longevity space seems to have their own journey and their own story on how they ended up there. And it's always great to hear yours. Let's start with a simple question, because I think you can really get to the heart of why we're all here today. And most health and fitness programs still operate many times just on guesswork, right? No data. Patients get frustrated, providers get frustrated, and practices will often struggle with engagement and retention because there's really no objective system or no objective data system that's guiding the patient journey. And today we're actually going to show you how leading optimization, longevity, and performance-focused practices are using the metabolic data, specifically DEXA for body composition, resting metabolic rate, and VO2 max testing, establishing clear baseline, creating a very measurable program that can really help improve outcome, increase patient engagement, and drive that recurring revenue. And we'll talk a little bit more about all of this. And most importantly, this isn't just about selling individual tests. It's really about building a system. So Eric, let's start with a bigger picture. Why do you think so many health, weight loss, and optimization programs really fail to produce lasting results? I know it's a big, heavy-weighted question to start with.
So one of the biggest, well, there's two main issues that normally happens. The client comes to you and you do no type of testing, no type of real analysis. You kind of just go through the motions. And in the beginning, they start to lose weight, or they start getting kind of like strength gains and neuromuscular changes, and people get somewhat better. But then that point in time, 2 months in, 3 months in, all of a sudden they start plateauing. And they start saying like, hey, what you're doing is not changing anything. Or I don't feel different, and we've been at this for 3 months. So how do you now elaborate to them that there is something happening to you, or you just have not really down on the numbers and will make this person change? So then that's where the clients kind of go, well, your program's not working for me. I'm going to move on and see who I'm going to talk to actually change my program and see if that works. And then they have this yo-yo effect where people try every other program under the sun and nothing still doesn't work. But it's not because it's not working, it's that people aren't really dialed down into the numbers. And I'll give you some examples. Like, super funny quote in the gym is called new lifter gains, where all of a sudden you go from like benching 50 pounds up to 100 in like 3 weeks. Well, yeah, that's normal. That's what your body does. It adapts really quick neuromuscularly.
Right.
So then what happens after that? You plateau. Same thing with weight loss. You start eating less, you change weight a bit, but then after that you plateau. Well, because your body adapts to it. You lost more weight. You use less calories and things like that. So when that plateau happens, that's where the business kind of starts losing their current clientele, and they have to start fishing new clients.
Right.
And getting a new client is harder than maintaining a happy, excited client that you're really taking care of. So that's one main problem. The people that aren't incorporating any type of analysis or any type of testing or any type of like, let me figure out who you are as a subject, as a person compared to someone else, because I might need to take a different approach for you. And then you have the scaling effect, which is people, like, I'll use myself as an example. I know a ton of stuff, because I have a ton of licenses and certifications, but it's difficult for me to replicate that for someone that just got out of school with a license and education and they're so green. So now that makes my job harder because I need to designate time to educate them. And I have to educate them in the proper way to make sure that they're almost like me, but not exactly like me. And that takes time. What would make it easier is if I could do a standard test, a standing operational way of the journey, like starting point of the journey for the client, where it's just quantitative rather than qualitative. So if everybody comes in, everybody knows how to do push-ups, as many push-ups as you can. Well, my staff member that just got out of school and doesn't just got their license will follow the same protocol and will follow the same standards. And now we could put them into a proper program. That's where most of these clinics lose their people because it's taking up too much time to educate a staff member when we could just include a diagnostic test like a VO2 max or DEXA or some form of metrics, and then my staff member could follow the metric guidelines and what we need to do for their programming. It makes it much easier. It cuts time on training. It cuts time on trying to educate them right away. They could learn through some of the systems that are in place. And it just makes it easier to retain clientele because now clientele don't think like, oh, this is a new person coming in. They don't know what they're doing. Right.
Right. But beyond that, it really sounds like, the implementation of data, beyond a new employee starting, but just overall working with your patients, working with your clients, right? And you mentioned something really important, taking it from subjective to being very objective as a starting point, establishing baseline.
Correct. So kind of from a consumer standpoint, if I come to an office and they're going through data as opposed to a subjective point of view, I feel more comfortable because they're not just pulling things out of their butt, right? They're not pulling things that they've seen subjectively. They're pulling things out of data. And data has been vetted for a long time.
Right.
That's why VO2 is so popular right now, because that's not coming from just like something that was developed a week ago. That's from years of developing where people should stand in.
Right. And we'll get into VO2 in a second, but let's kind of go into, and I guess we now understand, very clearly data is very important. Just looking at the body weight, not going to get us to where we want to go. If you don't have baseline data, it's going to be difficult to establish your programs, as you had mentioned. But now let's look at the different kind of product categories within the data metrics beyond just blood work. You'd mentioned DEXA for body composition. You'd also mentioned VO2 max and RMR, resting metabolic rate. I introed with that as well. If we start from a perspective of understanding what's happening inside the body, and I would think let's start with DEXA as a tool, and then understand once we know that data, then how does the RMR and how does the VO2 max help us go beyond and take our data from the DEXA and actually do something with all these metrics. Now, in this world, why is, I guess, two categories. Why does lean mass matter so much? Why is it important for us to track lean mass? And then a follow-up to that, which we'll get into right after, we're going to talk about visceral fat. But let's really focus in on lean mass for a minute. Why is it important to know what our lean mass percentages are and our body fat percentage?
So lean mass in general is associated with so many benefits. It's one of the biggest things and one of the things that people push the most. When you look at lean mass, we're also talking about non-fat tissue. So organs, tendons, ligaments, right? But lean mass in general is associated with strength, overall strength, how strong the person is, how well can they move. It's associated with hormone balance, glucose sensitivities, mitochondrial densities, mitochondrial size, mitochondrial efficiencies, force production. So coming back to strength, force production, how fast can someone produce force? Balance is associated with more lean mass because it is related to how strong someone is and how well can they recruit myofibers to move from one direction. We're also looking at, from a longevity standpoint, it's easier to provide blood flow to muscle mass than to fatty tissue. That really doesn't it doesn't do much, right? It's a well-polishing part of the system. When you think about it, the more muscle mass you have, the more efficient you're just going to be in life in general. And coming back down from a force production and a balance production, when you walk, you're producing force. When you get older, the more muscle mass you have, the less you'll lose as you get older. And that's pretty much the idea. Unfortunately, as we get older, we're going to lose muscle mass. We want to try and maintain that and avoid something called sarcopenia, right? Too little muscle mass in the extremities versus trunk. But again, it overall, you'll feel better, right? Mm-hmm. When we look at more lean mass for the person's height. There is a certain level too, as well. Too much lean mass could also be an indication of a problem, right? Most people don't talk about it, but you could have too big of a cardiac muscle, and that's usually not good when it's associated with a chronic disease. Mm-hmm. But
it's not really something that most people are thinking about.
No, most people are talking about lean mass, right? But at the same time, like, that's why there's different numbers on the DEXA that most people don't explore. So like the lean mass to height ratio, that's something that most people don't explore. Mm-hmm. But it's a good indication, like, hey, do you have the proper lean mass for your height that you're currently in? Mm-hmm. And then some other things that people don't realize is that the bigger you are, regardless if you train or not, you're going to have a significant amount of muscle mass underneath all those layers of tissue you have. So why is that? Because mm-hmm. they need to be strong enough to move all those layers of tissues, to be polite, right? Mm-hmm. But what happens if you start losing weight? Like if you go on a, GLP, and you lose the muscle mass, well, you just lost the good stuff that regulates your hormones and everything else to make you more efficient by compensating on losing all the weight.
And that's a real thing. You brought up two really important points as to why you do a DEXA, tracking lean mass. Hey, it's great. I want to see if I'm in shape. I want to check my body fat percentage, but so many people are so focused on only the body fat percentage and not considering where they're at with their lean mass, even though it's nice to look at, but not everyone's into working out and bulking up. So they're looking too much on the body fat. Now, you brought up two important things. One, sarcopenia. As you get older, it's a real thing, right? As you age, and something we have to be very cognizant of. And the only way to get that information easily is going to be with a DEXA. The other, at least you have to establish baseline and track. You have to show where you are now and where you are in the future. You have to track that, and that's how you can track rapid lean mass drop off. The other thing is that you brought up would be from the GLP-1s, and that's a reality also.
Not just touching on that, but also runners. So long distance runners, they're more susceptible to sarcopenia just because of the sport requirement requires them to be really lean at some point, and they use a lot of energy.
Burning muscle.
So, well, not just muscle, it's just an adaptation. So essentially, like, for you to go longer distance, you have to weigh less. But that also comes with the double blade, that if they're not doing their weight training and they're not doing their power performance stuff, they will lose some muscle mass, and they're at higher risk of getting sarcopenia when they're older.
Now explain that. Explain why sarcopenia is prevalent, but why be concerned about it?
Well, again, it comes down to the association of not having enough muscle mass to produce
Mhm.
force, which also entails loss of balance, which also is associated. There's not really too much of a, there is a relationship, but I can't say causation. Your bone mass will probably be lower too with someone that has less muscle mass. And it has to do this vicious circle. So the less muscle mass you have, the less active you probably are, and the less force you produce. So why do you need it? Which then makes you more frail. So if you look at older women that aren't really active and they're either, or they're osteoporosis or osteopenia, and there's no chronic disease associated with it, it's because they really don't have a great nutrition, or they're very sedentary lifestyles.
Mhm. Yep.
Why would your body want to give you muscle mass if you're not going to do anything with it?
You're right. You're neglecting that. Let's segue
It's
from there.
mu-
This, no, go ahead.
muscle takes
Last
up a
point.
lot of energy. Yeah, muscle
Yeah.
takes up a lot of energy. You and me sitting down here takes up a lot of energy compared to someone that's just sedentary and doesn't have
Mhm.
as much muscle mass.
Yeah. Yeah. So let's take that muscle, critical to look at. We want objective data. Now, someone comes in to a longevity center like, oh, it's my body fat. I want to do my body composition, body fat. Body fat is obvious. You can visualize it. You know when you feel, you have too much, or when you have just, where you're comfortable, just from a visual perspective. Important to look at body fat. Sometimes equally important, more important, would be to know visceral fat, right? And making sure that, and now we're quantifying three different numbers, three different metrics, right? Lean mass that you brought up, body fat percentage and pounds, and looking at this differentiator, compartmentalizing all this data around your body, and then visceral fat. Let's touch a
Yeah.
little bit on visceral fat, and then I want to get into the RMR VO2 and talk about how we're using all this data and why this next set of data is going to be critical for the longevity journey.
So visceral fat, to be plain and simple, you have subcutaneous, the fat underneath
Mm-hmm.
the skin, and then you
Yep.
have visceral fat. So non-visceral fat and visceral fat. Visceral fat being the easiest explanation is that apron that goes around your intestines and all your
Yep.
vital organs to keep you nice and warm. It also acts like a extra bank, like a savings account that you don't really touch unless you really need it. So that one, because it's under the abdominal cavity, it kind of takes up a lot of space and it will suffocate everything that's in there. But it also has hormone disruptive properties. So if there's too much, it will take some blood supplies, and it can add to like brown cells, white cells, fatty cell, like beige fatty tissue cells, and it just becomes more disruptive, and it's taking up energy when it's just sitting there. It's like a freeloader that comes in and just sits there and starts eating all your chips.
And it's
Right?
detrimental
It,
and can
it,
cause cardiovascular disease and
it
diabetes and,
more
and
at
other
risk
things, right? Yeah.
because it's also closer up to the chain where it's near your lungs, your spleen, your everything. Again, it's taking up space. It's being a
Right.
pain in the butt. That's the easiest way I like to explain it to consumers. But it's being that freeloader that's you have like 100 square feet to live in, and this guy's taking up 50% of your living space. That's a big pain in the butt. So one way to work on that, and I like to tell people that's kind of like your 3 month deposit marker. If you do everything right for 3 months, you eat, you exercise, you maintain, your visceral fat's going to come down more little by little versus your subcutaneous fat. And again, it's because of the blood supply and everything and the importance of it being there. So every 3 months, if you've been on a regular routine, it should start getting lower and lower.
Mhm.
The other thing with visceral fat is that it is, I can't say because I haven't gone through the white papers. It's been a long time. But every time I do a DEXA, I've noticed that there's a relationship with people that have done performance enhancing drugs or high dosage of hormone replacement that wasn't monitored or taken care of and hasn't been really looked at, they have a significant higher visceral fat content than the people that don't. So when we do DEXA scans, we want to look at that to make sure that whatever program someone's on, if they're doing a functional medicine program, a hormone replacement program, that they're following the standards, and that they're actually making sure that there's no increase of visceral fat while they're on a program. And there is, then, hey, we need to look more than just a DEXA. It's another purpose behind all this. You get to see some indications like, hey, there's something going on. I think we need to do further tests.
It's interesting.
Yeah,
and this is where data is so important.
100%.
Imagine you start a program and you have no data.
Well, yeah.
Sometimes
So like, this is why I like the DEXA. It's non-invasive. It's very quick. And then if you know how to read the report, you could tell, hey, you have a difference in one leg versus the other in muscle mass. You have sarcopenia, you have this X, Y, and Z, you have too much visceral fat. Like, why is this? And then you can either have a deeper conversation, or you could go and say, hey, we need to take another look at from a different angle, from a different approach. Yeah. Let's do this type of testing to see if there's something related to that. Like, and I've called it out, and it's funny enough, like most people don't know, but you could tell if someone has an autoimmune disease on a DEXA. You can. It's rare, but you can. When someone has a significant extremity deficiency from one side versus the other, and there's no logical reasoning behind it. So now it's like, hey, let's take a deeper dive into what's going on.
There's certain predictors. So you're saying there's certain predictors that, and it's amazing, right? Because the DEXA originally was just for bone health. It was all about bone density. Then it came into age management. It was all about body fat. But now we're talking about lean mass, track the lean mass, track the visceral fat, understand the differences. We're compartmentalizing. We're looking at left versus right. And then as a predictor, as a probable cause of other things that are going on in the body. And this is why data is so important, especially if you're just going into health optimization and longevity. Now, if we look behind you, right, there looks like a device back there, might be a monitor of some sort. You know, it looks like there's a lot going on with it, but that device does what exactly? Tell us about that.
This is actually this is actually a cardiac pulmonary testing. So it is to measure VO2 max, which is pretty much a hallmarker for cardiac pulmonary health. We're looking at how well can you use oxygen in to produce energy, and then the byproduct getting tossed out, which is CO2. So the one that I have here it's kind of like the baby version of their medical standard grade. But what's cool about it is that this one's portable, and it does have all the research capabilities behind it. So I could look at everything that this person does during a resting or even an exercise tolerance test. I could see exactly how the lungs work from breathing in to breathing out. I could see from the muscle exchange of oxygen and CO2. I could see heart rate. I could see when they spike, when they don't spike. I could see a lot of details.
Yeah.
And especially this one. If I wanted to, I could go into EKGs with him. I put up a second monitor, plug in EKGs, do that. And I could even automate the treadmills and any other ergometry through this little guy. But this is the baby version. The Mac Daddy is a little different.
And with this, you're doing resting metabolic rate, RMR, and VO2 max. You can do both, right?
Yep.
Let's talk about, we talked about DEXA. Now, I think we firmly established we need DEXA as a baseline test before doing anything. Let's understand what's going on inside our body. We know the body fat, we know the lean mass. Now we're ready for action. Next step, what is RMR? And why does that factor into this equation? Then we'll talk about the VO2 after, because that's the next
perfect
level.
So resting metabolic rate is basically the measurement of how much your body needs calorically at rest. after 8 hours of rest, sleeping at home, and a fasted state. And it's not to get confused with something called basal metabolic rate, which is a complete different test. It's more complicated. Resting metabolic rate is easier to perform. Anybody could do it. But the idea is to look at what this person needs to consume just to stay alive and not feel like garbage, essentially. So using that, we can now start creating a program associated with the person's body composition, right?
So if you're talking about the caloric burn just to exist, before you had mentioned just to go about our daily lives. I get up, get your breakfast, get your coffee, you drive to work routine, come home. We're talking about that kind of a calorie burn. And now when you do it, you're at rest, right? It's the resting metabolic rate. Typically it's a non-invasive. Tell us a little bit about that process. And again, what does that mean, from a rest perspective? Are you sedentary at that moment, or is it incorporating your calorie burn rate for the entire day? Like, what is that actually including?
Yeah, so let's narrow down the definition a little bit. So resting RMR, resting metabolism, it basically is just the base straight baseline. So it's just someone that would just lay in bed the whole day and would have to get up to go pee and come back to bed. That's it. Versus something that's called total daily energy expenditure, which now you're taking into account the person's day-to-day activity, what they're doing, plus exercise. And we could get down to like the thermal effect of foods. It's not a lot, but essentially now we're taking all that into account. Okay. So very brief, someone could have 1,500 calories at rest, doing nothing, just getting up to go pee. But that person now is not sedentary. They exercise. They exercise for about an hour a day. They're walking around. They have to work. They get about 8,000 steps a day, and they're eating mostly protein. So now that resting metabolism is different from their total daily energy expenditure, which could be 2,500, just as an extra stuff. So on that day that they're active and they're eating what they're eating, estimated 2,500 calories is what they need for that day versus what they need to survive, which is 1,500 calories.
And a day they don't work out and don't exercise.
And the day that they don't work and they don't exercise. So this is important because you have days that you don't exercise and do anything versus days that you do exercise and do everything.
Right. Yeah.
Most people forget that you don't gain weight in one day. You don't lose weight in one. So one day you could have a really good caloric intake, but then the next day will be terrible. That adds up in a week. So by narrowing at least down to the numbers that we need to look at, we could give you some ranges and we could really take a dietary approach to it. The other fascinating approach to looking at resting metabolic rate is to see if, and most people don't think about this, is if they're overtraining. So if they're an athlete and they're overtraining, or they're on a specific diet, right? Because it really is just you get up, you don't eat anything, you do the test, and that's it. If they're overtraining, if they're on a specific diet, if there's a disease, you could tell just from the ventilation of it. So you could look at ventilatory stuff, not as great as the VO2 stuff, but you can still see it.
Okay.
But I'll give you an example. I could tell if someone's diabetic by having an RMR. Is that rest, a diabetic will burn more carbohydrates doing nothing, which is not normal. We usually burn more fats doing nothing. But if I see that, hey, you're getting to 0.9, 1 point or 1 point something, then hey, you got something going on that you're using glucose at rest. That's a problem. So we need to take a deeper dive in your testing.
Right.
Same thing with
Again,
someone that does,
another objective data point, really
yep,
important.
same thing that people do like fasting. Like they like to do fast, 16-hour fast, 12-hour fast, or like 3-day fast, or some people are very interesting and could do like a week fast, and I'm just very impressed with them. Or they're in a high protein diet, like straight keto, or they're on the carnivore diet, or they're over like training significantly. You'll see that they're using more proteins at rest, which is, again, we need to see why that's happening, whether it's because it's a dietary thing, a disease thing, or you're really just overdoing too much, whatever it is you're doing. Like you don't want to burn proteins at rest. That's not good.
Now, if you're in a typical health optimization longevity office, right, consider clientele 40 to 70, 50 to 70, you know, 40 to 65, whatever the range is, but that's typical, you know, for typical age ranges. Where would, if you, now we're looking at 2 data points, DEXA and RMR. We haven't touched on VO2 yet. What would be the most significant, you know, impact now? And I think we've covered it, but of understanding now where we're at from a body composition perspective, body fat, lean mass, visceral fat. Now we're looking at the resting metabolic rate, or we're looking at the RMR, and you mentioned a bunch of other good data points that we can get from the RMR. It's not just caloric burn rate and your at-rest metabolic burn rate. There's more, but now how would you correlate this, looking at where somebody started out with and where we're going to go with them? How are we incorporating both of these data points? And how significant is it to have both of these data points?
So if you're trying to change body composition, right, you need to have an understanding of what they need to consume. That's one of the easiest things, right? A lot of body composition, it's always built through the kitchen and what they're eating on a day-to-day. And when you give numbers to people and you put it in a numbers perspective, it makes it easier to make sense that, hey, you're doing something that's over exceeding this. So if you come in and you want to lose weight, right, it depends on the program. That's the other thing too, whether they're doing peptides or they're doing all these biologics. But let's just say, to make the argument simple, they're coming in to lose weight and maintain muscle mass. If you put someone in a severe caloric deficit, they're going to lose both. It's going to happen a lot, right? Not only that, it makes it harder for the person to exercise because they won't feel like they have enough energy to exercise. And that's also a different frame of mind.
Right.
So you could take a simpler approach. You could be nice with them. They could come in, they have 20% body fat, right? Which is not terrible, but they want to get leaner. They have 100 pounds of muscle mass and they have 30 pounds of fat. Okay, let's do an RMR. It shows that your resting metabolic rate is 1500. They're a sedentary person. They're not doing any activity. And you estimate their total daily energy expenditure to be 2000, just to keep it simple. I could now be very kind and say, hey, let's just cut 250 calories from your diet. So don't have the extra Snickers that you're usually hiding around, or don't have the extra tub of ice cream that you shouldn't be having. Maybe let's reduce it down to like a cup of ice cream, right? So we could put a picture like, hey, cut this a little bit. I'm not telling you to completely cut off of it, but cut off a little bit of it. Start looking at what you're eating. And then let's add some walking to the equation. So now you change your total daily energy expenditure from, I said 2,000 to 2,300. If I have them do 8,000 steps a day. And I took away 250 calories from whatever they're currently eating. They're supposed to lose more than a pound a week if they're consistent with that. And it's very easy.
It's a very good mathematical equation.
It's not aggressive. It's not nasty. It's very gentle, but it also depends on the person I'm talking to. And that's where the human equation comes in. But at least I gave them numbers to start figuring out in their head. And I converted it into something simple, like, hey, just walk more and don't eat that Snickers that you like to eat.
Avoid the bad things, cut down on sugar, right?
Right.
You don't eat packaged foods, diet and exercise is what I'm hearing.
Right.
But now you can put a number to it. So now you start in the beginning, you talked about the yo-yo effect where they go somewhere, they don't see a result. And we want to avoid all that.
Yeah,
this is
and that's
kind of where we're getting at for these.
And that's the thing with people. They get into like these extreme diets, they can't maintain it, or they suffer and they just hate it, and they don't sustain it for the rest of their life. And again, this is just an example. There's a lot of different approaches. It's also different when you start adding, your diet's going to be different when you start adding GLPs, or you start adding peptides, or you start adding like hormones. That's going to be the dietitian of that practice.
Right.
And whatever that practice is dictating to make sure that it compensates for it.
Yeah.
So now that's a whole different approach, but at least you have a quantitative number. And then there's years of research and data that could be plugged into it.
That's right. Yep.
So like go ahead.
No, go ahead. Finish on that.
Well, like I was going to say, the regular RDAs for dietary, that's the basic of the basics. And there's other numbers for performance athletes, and there's other numbers for someone that wants to be more ketogenic. Now they could all make their decisions and their programs from at least a starting number.
Yeah. And this brings us to more data. We could even reference, the body composition scales in the homes, collecting data on a regular interval. We'll save that for another talk. Getting into more information, right? We're talking about the DEXA, which is typically like a 90-day follow-up. Is the same with RMR. We want to do 90-day interval follow-ups, and are we going to see changes in that 90-day period with the RMR?
So, that's usually something and this is what I tell people, resting metabolism is not easy to change. It's not that simple. It doesn't just like switch right away. So your resting metabolism, you actually want to give it a little bit more time. 4 months, 5 months, you want to give it more time. But here's the thing. That's just for someone that's not taking anything and it's not on a program and does not have an associated disease. If someone is doing a specific program and there's a significant notice in weight change and weight
HRT, that could be GLP, that could be exercise, diet,
then
putting them on a program.
Then you would do the resting metabolic rate sooner.
That makes sense. Along with the DEXA.
Along with the data, because it's a significant change.
Right.
And you need to, because let's say if you went from 200 pounds to 180 pounds, that's a 20-pound difference. Your metabolism is definitely going to change. Right. Your resting metabolic rate will probably be a little lower. If you maintain a good amount of muscle mass, it will be not too significant of a change, but there'll be a huge change. And that's one of the reasons why people don't lose weight, because they stay at this one diet that they've been on for a long time and they forget they weigh less. So guess what? You need less calories to move around.
That's right. You got to track. And that's where all the good information comes from.
Yep. Your body gets really efficient. Like, again, that's why marathoners are the way they look. They're a lot thinner because your body got really efficient in being able to use energy forever. Right.
And that brings us to another equation. Now, runners, you're into athletics, not athletics. People are running around with their Garmin watches, their Apple watches, their Google watches, whatever watch they have, and they talk about steps. How many steps? You talk about steps, right? And I'm shocked. Some days when I'm on vacation, 30, 40,000 steps a day, right? It's easy. Office days, even with a standing desk, you could barely even hit 3,000, right? If you're not purposely going out to run or something like that, right? But then the other number is calorie burn along with your heart rate. There's another important metric, right? VO2 max. Now, you have to take everything with a grain of salt on your watch because it's, using a light to go into your wrist and look at blood flow, whatever it's looking at. But the data is going to be relatively compromised, right? It's not perfect, but it gives us a day-to-day, hour-to-hour, minute-to-minute check-up on what's happening within our body, right? And if you see rapid heart rate, you're okay, now let me go monitor it, but heart rate's changing, something's going on. But let's talk about the VO2 max, because we have, again, DEXA, we have the RMR, VO2 max, three really important metric data points to establish for a baseline before setting up a program and also follow-up. Now, we've really come up to the conclusion that every 90 days is a good timeline to repeat your DEXA, repeat your RMR, especially when you're on a program making changes, and allows you to monitor your progress and make adjustments as needed. VO2 max, is this only for athletes and runners and things like that, of that nature, people that are super active? Where does the VO2 max come in? Why is it significant? But so let's kind of break it.
So VO2 in general is the volume of oxygen that someone can consume. And then max is the maximum amount of that volume that you can consume.
Okay.
Easiest way I could say.
Okay.
So we're always using that equation. So right now we're inhaling, we're taking a volume of oxygen now as we speak per minute. Okay. Max is just the maximum amount that I can do. So the main purpose of VO2 max is to see how much is the maximum uptake that someone could take in to produce oxygen. To produce energy. My apologies. And that's important because everything requires energy. Everything requires energy to do something. When you sleep, and this is something that people don't touch on, you're using 1 met. That's the metabolic equivalence to energy. 1 met. 1 met is equivalent to 3.5 VO2. When you walk outside, if you walk a leisurely pace, it takes about 3 mets, close to that, which is equivalent to, I'm going to round it off, about 15 VO2, right? So if you notice, everything requires energy, and we can convert that to VO2. So what's related to VO2 max is how well can your body convert things to energy, and that is a long process. It's a huge process that we don't really pay attention to till we pay attention to it. And it starts off with the amount of oxygen we take in, the 21% that's in sea level, and then from that breath to my lungs, we lose 2% of that because it gets perfused into the tissues. Then from the alveoli, from the lungs to the alveoli, to the heart, through the arteries, all the way down to the capillary, like the red blood cells, the capillaries, and down to your mitochondria, you only end up using 2% of the 21% that you took in. So if I can improve all of that from the moment I take that breath in to the mitochondria level to create ATP, to now taking the CO2 and buffering it out, my VO2 would be better if I could change any of those things, right? So it doesn't matter what type of program you are, but if I can manipulate any of those factors, and it's called oxygen cascade, it's the easiest thing that will help you kind of find the narrow down the pathway. If I could change any of that, then my VO2 max will go up. So from a athletic standpoint, from a chronic disease standpoint, from a normal person, if I look at their VO2 max and you have, let's say, a chronic disease, a good one would be COPD, right? Okay, now I know like if this person is sitting 25 VO2 max, it's most likely because of their lungs. So if we could improve lung capacity, but also a heart and circulatory capacity, and I could get them up to 30, that's perfect. So what can I do with someone with COPD? Well, I could have them walk more and just make sure that they don't get too low on their oxygen. I could have them do breathing exercises to improve the amount of air I could take in. I could help them learn how to buffer out more stuff by exhaling more and understanding more diaphragmatic education. So I could use it for almost any kind of disease and narrow down like, hey, what if we do this one thing? Will that improve this person to get better? And then from an athletic standpoint, like, hey, I don't think there's enough that we could change lung-wise because they do a lot of breath work or they do a lot of training cardiopulmonary, but what if we help them build more muscular endurance to build more mitochondria density? I could convert more energy if I have more mitochondria, right? So they're going to technically have a better VO2 max, or I could change on how much force they could produce per step. If they have
just by
stronger
monitoring the
muscle,
VO2 max.
just by monitoring the VO2 max. So all these things could be associated with VO2 max. VO2 max is also related to weight.
Okay.
So the bigger you are, the more oxygen you're supposed to take in and convert it to energy. If you don't do that very well, then your VO2 is going to be garbage.
Yeah,
So
the VO2 can be improved from what you're
it
saying.
could be improved just
Different
by
exercise, but you have to understand where it's at.
Yeah, just by changing body composition, their VO2 will go up. If you have someone that's like, so this is where DEXA comes in and why it's important. If you have someone that has 30% body fat, they're carrying a body fat that's not really helping them push their VO2 max. But if I bring them down to 20%, they're going to be leaner, they have more muscle mass, and they're still having the same amount of air coming in. Well, they're going to be able to go further, which entails more efficiency, which means that their VO2 max is going to be up. That's why even if they don't do exercise, but their weight changes, for the good part, their VO2 max goes up. And that's why a lot of the integrated health space are now linking it to longevity, because I could take a peptide, I could take a GLP as long as I don't lose any muscle mass, and my VO2 max will go up. I could take specific peptides to help me produce more mitochondria or NAD and all this other stuff, and that's a whole different topic. But if it's anything that can manipulate that whole cascade that I mentioned earlier, then my VO2 max is going to go up.
And you want to monitor this, right? Is there a risk of having well, let's start both sides. Is there a risk with having too high of a VO2 max on one side? And then what is the risk of having too low of a VO2?
So the high portion, I really don't, I haven't seen or I haven't read any documentations on having too much of a high VO2 max.
Yep.
The only thing that could be associated with risk would be more of a cardiac component that most people don't really pay attention to. And it's very rare. You know, I don't think you've ever heard of the term like sudden death syndrome.
Yep. Yeah.
Where athletes just suddenly like collapse.
Yep.
It's a cardiac thing, and there's still not kind of like a narrow down of why that would happen. Some associated with myocardial infarction, some of them associated with myocardial hypertrophy, like too big of a heart, and it just stops. Some of them say it's electrical physiology that just goes haywire. But that would be the only bigger likelihood when someone's training that high that they might have that type of event. Like too much of a great thing could actually hurt you. But that's why you want to get tested regardless. Right?
You want to look at other parameters.
But it's very, but it's like very little if there's no disease associated with them. There's usually something tied with either genetics or their
This is
family
outside of
history.
VO2 max anyways, right?
So now
go
the
into
worst
like a
side.
low, the worst
Yeah.
side. Somebody comes
So-
in, you look at them, you want to optimize them, low VO2.
So low VO2 is someone that can't do much. They just cannot do much. So they used to say, and they probably still say, if you go read into a book, and this is why people are freaking out, they used to say that when you have like 25 of a VO2 max, like your maximum capacity is 25, you have a 5-year life expectancy if you don't change that. And it's because 25 VO2, if we take the math, it's equivalent to about almost 7 MET levels at max, right? That's equivalent to you doing a 6-mile jog, 6-mile-per-hour jog at max, meaning at maximum capacity, you could jog. You're not going to jog for a long time, basically. You can't sustain it. That's your maximum capacity.
Right.
That's a problem because if we cut that in half, walking, you lose air just walking to your mailbox, essentially, right? At 4.5,
now we're going to measure. We're going to measure across the spectrum. Now people are going to come in, going through optimization. I feel sluggish, brain fog. You know, they're just more sedentary. They're gaining weight. Whatever the situation might be, we got to look at DEXA.
Yeah.
Got to look at RMR, and we have to look at the VO2. It sounds like, and there's many locations that are missing out. They might just look at DEXA. They're missing out on RMR, but now they're missing out on VO2. And if we're establishing a clear baseline, is from what it sounds like, from what you're saying, in order to establish a clear baseline of health, we get the blood work that tells us a lot. DEXA, we're getting really good data, RMR, and now this missing item that a lot of places don't do, which is the VO2 max. And it's easy to do too, right? I mean, it's,
yeah. So then the other issue is that people get stuck on the number. It's not about the number. It's about how this person gets up to that number.
right.
That's the most important thing. And that's what people don't pay attention, especially if you're working with chronic disease. Like, you're going to have people that have blood pressure problems. How do you, what is their blood pressure going to do when you have stress? It's going to go up. How does it react to that person going into exercise now on a higher intensity?
Right.
Does it get significantly too high? Then you have people that have movement diseases, like they cannot move, bradykinesis, like Parkinson's, things like that. Like, what are they doing to get to that level? It's probably not going to look great, so you need to address that. So it's about how they get there. That's important. And then what, if they are on medications or they're well managed, what's happening with their physiology to get to that level? And that's what people don't realize. Same thing from an athletic standpoint. What is their body doing physiology-wise to get to that VO2 max if you really want to dial down onto what could help this person?
Yeah. But now the average person that come in to a clinic, provider has the RMR, they sit in a chair comfortably, breathe through a tube. You're holding up that mask before. What is the typical experience for the VO2? Let's talk a little bit about protocol, and then we'll wrap it up. But I just want to bike, treadmill, specific, like what exactly, for the.
I also want to clear up the RMR. You don't have to. So resting metabolic rate, the gold standard now, is a hood cap.
Okay.
Yeah. So it's actually a cap that goes over your head, and it collects the air that's in that cap.
That's good.
Versus breathing into the tube. They both work, but the gold standard is now the hood cap.
The hood cap. Great.
The hood cap. And it's comfortable versus me breathing into a tube.
Yeah.
Because you have to also pinch your nose.
Right. It's not comfortable.
With certain devices. But regardless, protocol for the VO2 max. There's a lot of ways that you could do it. Some people are very, depending on the practice and depending on the researcher that's doing it, they get very specific on it. Some of them like to do it on like, don't eat, you know, um, X, Y, and Z. I always play it the safe way, and I've been educated the safe way, and all the textbooks say it. Prepare yourself as if you're going to do activity.
So don't have a full meal.
Just prepare yourself like you normally will,
Yeah,
because you're going to have people that cannot eat.
Like,
well, it's so a couple things, right? You need to look at, can this person actually walk on a treadmill? Is there any physical limitations that they cannot do? So they might need a bike.
yeah,
Some
bike
of them
or,
have
bike or treadmill.
Yeah, not only that, some of them can't do a bike because more physical limitations. So now you have to do an airdyne instead with the
Okay.
arms. So that gives them
So
the
there's
option.
options, a lot of options.
Yes.
What do
You
people
could do-
prefer in a practice environment? Treadmill, great for athletes, big base, right? Lots of power. You know, bike seems like it doesn't take up a lot of space and it'd be easy to
Right.
implement overall.
So
What's your preference?
from a, let's keep it like a lot of options for people.
Yeah.
There should be a treadmill and an airdyne.
Okay.
Those are my two main options. And here's the reason why. Treadmill, everybody likes a treadmill. They could just walk on it, and I could do different protocols. I could do an incline protocol. I could do a no incline protocol. I could do a speed protocol. I could do a non-speed. I could adjust it based on who's going to get on that treadmill. There's about 15 different protocols, if not more, on treadmills.
The treadmill. Okay.
The bike, there's not really a lot of protocols, but some people don't want to get on a bike because they just hate it. They don't train legs, and you're only using the lower body component versus using the whole body like a treadmill. But when you had an airdyne, now you give them the option of the full body, the arms, the legs. It's much easier. So if you do have someone with knee problems, they can still crank it out with their arms. Right? And it's a full body.
Okay.
So I usually prefer a treadmill and an airdyne. And you kind of knock out everything in there and what's possible. But VO2 testing, you could do it in any device. You could do it with any type of ergometry. You could do a step test with no ergometry. You could do the other day my treadmill took a dump, so I did a stepping protocol with people.
Yeah.
The idea is to get them to a higher level of activity and try and max them out as much as I can with activity. And like I said, it could be anything. But when it comes to a protocol choice, can they move? Is there a specific sport that they're doing? Is there a specific reason they're training? Are there any contraindications that I need to look at, whether I need to put them on a treadmill or a bike?
Yeah.
Like if you have someone with vertigo, I don't think a treadmill will be so great if they lose balance. Versus an airdyne, if they lose balance, they're seated.
Yeah.
It's hard for them to topple over. So there's a lot of things to consider when someone comes in to do a test. That's what I would say from a protocol. And then again, from a testing standpoint, let them take their medications, risk stratify them before that, and then prepare them as if they're going to do activity, whether they eat before activity or they don't eat before activity or they have a minor snack before activity. Let them choose that to what they normally do. I usually like having something before, and I will also offer them something after, especially if you're doing concierge practice. I'll offer them a smoothie or something.
Yeah. I mean, this is really great. Overall, everything that we covered today with DEXA, RMR VO2, incorporating a metabolic component, metabolic pillar into the practice gives us a lot of predictive information, establishing baseline, not just being in a very subjective mode with the program and not knowing exactly where someone started, where they ended, other than measurement body weight. obviously can be very inaccurate, and patient retention might drop off. So now we talked a lot about in detail, right? Even going through being able to have a personalized journey for the patient based on their own construct, what's going on in their body composition, what's happening with their RMR, what's happening with their VO2 max, which is really important. Tracking and measuring changes over time, really important. We also talked about and touched on some themes that Eric brought up with mitochondrial health, cardiovascular efficiency, recovery, longevity, endurance, performance optimization, and at the end of the day, measurable data for measurable outcomes, measurable improvement, all very, very important. If this conversation has resonated with you, the workshop is where we actually go deeper into this information: metabolic, recovery, therapeutic. We get into business of building out a destination health optimization practice, as well as marketing, and a lot of great information over 2 days at our workshop. We cover everything within the metabolic that Eric talked about with some hands-on. We get into recovery. Why is recovery pillar important to the health optimization program? And then also therapeutic, going into details like shockwave therapy. So covering a lot of information over 2 days. And so through that, we want to go over implementation, workflows, even some of the pricing and different models and memberships. You know, why is retesting so important? What does that patient journey actually look like? Now, this isn't just looking at procedural-based medicine. It's about helping to build out a destination practice. It's about building a measurable, scalable, modern health optimization practice. And if you want to check out the workshop, you go to anatomylab.com, ANATOME, lab.com will be in the description with this webinar content. And so, Eric, thank you very much for joining us on this webinar, which was really, really impactful. The metabolic webinar, why the best longevity practices measure more than weight. And that's DEXA, RMR, VO2 max. Again, Eric, thank you very much. Look forward to seeing you with us on another one.